So yeah, there are a lot of things that David said about me, but the one thing that makes me very proud is that I get to be associated with an organization that's made its mission to conquer CHD, not just its mission, but in its name. So thank you to Conquering CHD for allowing me to be a part of you, for allowing me to help with the scientific advisory committee, and for allowing us to understand that health disparities in congenital heart care is real. It matters. It's here, it's staring us in our faces, and we need to take it on and make it different. Why? Why? What's the need to make a difference? I mean, it's congenital heart disease, right? Heart's a heart. Turns out that this very severe hypoplastic left heart syndrome, only one ventricle, no ventricle on the other side, this heart can be in this baby, or 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 back to this baby. Congenital heart disease does not pick its victim. Congenital heart disease equally dishes out difficulty to everybody. So while we're all really focused on this heart, remember that this heart cannot exist in isolation. This heart exists within one of these amazing young babies. And so while we think we're caring for this heart, we're caring for this baby, and we're caring for this baby's family. We're caring for this baby's environment. We're caring for this baby's growth. We're caring for this baby's community. It's up to us to make a difference, not just to this heart, but to this baby and to everything that this baby and this baby's family represents. Overall, speaking about how we provide congenital care, we've actually gotten a lot better. If you follow over the years, outcome for congenital heart disease has significantly improved. Choosing hypoplastic left heart syndrome as an example, in the 1970s and 80s, this was a uniformly fatal disease. Today, greater than 80% of neonates with hypoplastic left heart syndrome are discharged from the hospital after their first operation, doing very well. But is that outcome uniform? Here is a beautiful study that was published from Texas recently that actually looked at all-cause mortality and congenital heart disease specific mortality and took the ratio of these mortality rates between non-Hispanic Blacks and Caucasian white individuals, or Hispanics and white Caucasian individuals. And as you can see in the graphs below, the dotted blue and the dotted red lines show us the ratios for congenital heart disease specific mortality in Black versus white and Hispanic versus white. And starting from 1999 to 2017, even though overall mortality may have come down, there still is a disproportionately higher mortality that is seen in Blacks compared to whites and Hispanics compared to whites. Even today, this is in late 2010s, 2017, 2018, our outcomes differ based on the patient's ethnicity, race, and potentially gender. And this is just overall data. Here is data that is very specific to, let's say, tetralogy of transposition of great vessels. Again, you can see the non-Hispanic whites have the best survival and the non-Hispanic Blacks have the worst survival. If we move on to a disease like pulmonary atresia, again, the difference is very statistically significant, with the non-Hispanic whites doing better than both the Hispanics and the non-Hispanic Blacks. Why is that? Care is better, we're better, surgery, medicine, hospitals, everything is better. Why? Why does there continue to be a fundamental disparity in the healthcare outcomes? This difference may start way before we even understand it. There may be an underlying genetic difference that is driven by ethnicity, that is driven by race, that is driven by country of origin, that's driven by gender. And these may actually impact the incidence and severity of heart disease. Here in the bottom is a study that was published from England that took all patients with Down syndrome and separated them into patients with Down syndrome who had a heart defect, a specific heart defect, versus those that did not. and actually genotyped them, studied their entire genetic makeup. And it appeared that patients that had Down syndrome but a higher incidence of congenital heart defect had more genes that could be traced back to a sub-Saharan African heritage. In other words, there may be a genetic predisposition that increases someone's incidence, prevalence, or severity of congenital heart defect. Without going into the details, we're only scratching the surface of this. We need to begin to understand that there is a biological basis to healthcare disparity. And why is that biological basis important? From here on moving forward for the next 5 minutes, I will try and prove to you that there are modifiable and unmodifiable risk factors that control healthcare disparities. The unmodifiable risk factors are unmodifiable. But we as stakeholders in congenital heart disease, we as parents, we as family, we as physicians, we as care providers, we as the society owe it to address the modifiable risk factors that lead to healthcare disparities in congenital heart disease. So what could some of the modifiable risk factors be? Now we understand that there is a genetic predisposition, but there is also an environmental or social impact that further exacerbates race and ethnicity. It has been clearly shown that certain ethnic or racial backgrounds happen to live in areas of higher environmental pollution. They may have more social deprivation. They may have coexisting diseases that are unrecognized, like diabetes and obesity. They may have varying maternal age at which they become pregnant. All of these contribute to the incidence of congenital heart disease in the offspring. So here are clearly modifiable risk factors. Here is an ability where we can intervene, increase people's understanding and recognition of disease process, improve living conditions, and directly impact the incidence. I'm not even talking about therapy. I'm not talking about improving outcomes. I'm talking about the most fundamental aspect of congenital heart disease, and that is the very incidence of congenital heart disease. It's not just that they are at a higher risk. You add insult to injury. Again, this study from England clearly showed that when you stratified patients based on the most economically deprived quintile to the least economically deprived quintile, and then plotted the incidence of congenital heart disease stratified by racial and ethnic difference, you can see that it is the Asian and the Black communities in the most deprived socioeconomic status that have the highest incidence of congenital heart disease. So now you take a genetic predisposition, increase the incidence, and make them socially and economically deprived. It is not a surprise that healthcare disparities are real in 2021 in congenital heart disease. Now, if you start off with such a significant health disparity, even starting off baseline with race, this study that was published with data from intensive care units by the University of Washington in Seattle clearly showed that the adjusted mortality rate, this vertical dashed line, is the reference mortality rate for Caucasian whites. Postoperative mortality, adjusted mortality, was statistically significantly worse for African Americans, and worse, but did not quite reach statistical significance even for the Hispanic population. And when they tried to understand what was the underlying cause here, they saw this linear relationship between race contributing to the severity of illness and therefore increased mortality. So here is clearly an example that race provides more severe illness. And therefore, if we can interrupt right here between this connection between race and illness severity, is another opportunity for us to bridge this gap in healthcare disparities. But is it just about how you're born? There's nothing we can do about this? It's where you live? It clearly is not. We as care providers have an opportunity to intervene and with intent try and reduce the disparities in healthcare. We the providers, we the families, we the society, we the administrator of hospitals have an obligation to understand that the stethoscope that goes on the baby's chest should be agnostic to anything else that may be hurting the baby. In fact, I'm going to add to it to say it must be even more aware of what happens behind that stethoscope in the baby, because racial disparities in medicine is a reality. It is not that people are intentionally trying to be disparate. It is not that people are intentionally trying to not provide care or withhold the best standards. But there are multiple different aspects that go into these racial disparities. As this wonderful article that was published by Zelaya shows, medicine is not colorblind. There are clear racial disparities that impact congenital heart disease outcomes. And why is that important? That's important because for some of us as providers, there is implicit bias. There is unconscious bias. There is this physician, as you see in the picture, that may not exist. We may be, in an implicit fashion, having a different conversation with a mother that looks a certain way and a different conversation with a mother that looks a different way. How do we bridge these racial disparities? We need to bridge these racial disparities because these disparities impact access to care. Whereas everybody's access to care should look like how it is in the top left, where everybody has equal opportunity to sit at the same table. Unfortunately, a lot of access to care looks like this. Data have shown that people are traveling 50 to 100 miles on an average to get surgical care for congenital heart disease. In this study, when you followed patients with age and saw how many of them kept following up with their physician for congenital heart disease, the probability of still being followed rapidly declined as the child aged. But again, it declined at a much faster rate for the non-white population than it did for the white population, because this care, this need to give up their work, this need for the sole breadwinner to have to not be able to put food on the table just to get their child to congenital care is unacceptable. This is a modifiable risk factor. We can make a change. And what changes we can make, we're going to go through the various panels today and try and see how we can impact this. Is there a tiered system? Could you provide entry-level care closer to home and more complicated care farther away from home, so we reduce the number of times that they have to miss work? Could we have weekend clinics? Could we have weeknight clinics? More, could we go to their houses? Add to the fact that this is compounded by literacy and language problems. What looks like a very linear relationship to the physician here is a complete tangled mess to someone with lower health literacy. There are language barriers. David and Rebecca and Amy and I have talked about this. We put amazing data on our website, and there is a large subspecialist group, a large stakeholder parent group, a huge community that just can't even read it. They have no access because even though we think we're all sitting on the same table, we're saying different words. So no matter what one person talks, the other person basically sees a jumbled words and a giant question mark. Health literacy, language problems are real, but easily modified. Now we're moving gears and talking about one last thing, is how people get insured. This was a very curious study that looked at mortality risk among Black infants who have congenital heart disease from birth all the way to 1 year. And this was very interesting. Immediately after birth, it appeared that Black infants had reduced risk of death. But in the post-neonatal period for the first year, there was a 70% increased risk of death if they had public insurance. In other words, whereas we may be doing a really good job of capturing these children early, as soon as they are born in neonatal intensive care units, once we take care of them in the neonatal period, they get dropped off in a bus stand. That's not okay. Here is a modifiable opportunity to provide continuity of care. And continuity of care is not just in the neonatal period. As we're going to discuss later today, this continuity of care is even more important as we talk about adult congenital heart disease. What happens when all these patients now suddenly are not followed by pediatricians? They are followed by adult doctors. And how do we make sure that this health disparity does not carry on into that world? This is important because today's teams don't look like these. This team wins, no question. But this is not how today's winning team looks. Not every winning team has all the oars that look the same, point the same direction, and everybody's wearing the same white hat. This is not what today's team looks like. Today's team, we have a clean slate. We have an opportunity to make a difference. We have an opportunity to make a team that we think will benefit, as Scott Page says, from the diversity bonus, from the ability to bring people with completely different perspectives onto the same table, and clearly make sure that we can reach this healthcare equality index that has been put together by the Human Rights Campaign, that promotes equitable and inclusive care for all people, lesbian, gay, bisexual, transgender, queer in this instance, but people who differ in race, people who differ in gender, ethnicity, background, learning, socioeconomic factors. Because today's winning team, if it takes this perseverance to land on the Mars, the team no longer looks like that ore. The team looks like this. It's made up of people who fundamentally look different. It's made up of people who fundamentally act different. But together, they can easily get this perseverance onto Mars. And that's what we need to do, is to try and get a team that works like this, so congenital heart disease becomes a thing of the past. This conference and this meeting is going to help us understand what goes into these things. What could we do to make a difference? Because if a perseverance can go on Mars, certainly medicine can figure out healthcare disparities in congenital heart disease. Again, this has been a terrific opportunity for me. It's a great opportunity for all of us to discuss healthcare disparities. I'm going to stop there and turn it back to Rebecca and David, and let's get this ball rolling.